Hello, everyone. Today we want to talk about the concept of pain. I want to explore the physiological mechanisms associated with pain. Now, pain is a submodality of the somatosensory system, but it's a very important component of the human experience. And as a doctor, you might expect that many people will come to you because of pain. As a research scientist, you'd be very interested in understanding the physiology behind pain. And so, given the fact that pain makes up such a large component of the human experience, it is very important that we understand what is going on. Now, you will see on your screen a definition for pain. And notice it's defined as an unpleasant sensory and emotional experience that's associated with potential or actual tissue damage. And inside of that definition is a very important concept, the concept that pain is an emotional experience. Nociception is a physical process of transduction that gives rise to the sensation or the perception of pain. If you think about the difference between sensation and perception, sensation is the actual process of transduction, so we can call that nociception. But perception is what your brain understands, how your brain interprets an event. When it comes to the sensation of pain, that perception has a very large emotional component. And that's the reason why two people can experience the same event, but have very different experiences of the pain associated with that event. Now, to help us focus in on the fact that pain does have an emotional component, I just want you to look at this particular image. This is from an fMRI study. And as you know, fMRIs highlight areas of the brain that are active during particular processes. So in this particular study, the individual is experiencing pain. And what you notice is two parts of the brain light up. Two parts of the brain are shown to be active. The first region is the one I'm highlighting here, the somatosensory cortex. And of course, that is not unexpected. The area of the body that's experiencing the pain will detect it as pain, and it will show an activity in that region of the body. But the second region that's activating is the anterior cingulate cortex. And this part of the brain, this region we know is very important in the processing of emotional information. And so here we see that concept we were just exploring, the fact that pain is a combination of nociception and your emotional perspectives are very nicely demonstrated in this fMRI study. And just to take it a little bit further, the image below shows somebody in observing another person who is experiencing pain. Well, notice inside of this fMRI, because you are the observer, you are actually feeling the pain yourself within your somatosensory system. But the emotional experience is actually taking place. So the same areas that are involved in the emotional processing of pain for you as an individual also appear to activate when you're watching another person experience pain. And we believe that that is part of the neurological or biological basis for some aspects of empathy. Now, this concept of pain having an emotional component means often it's very hard to come up with an objective measure of pain. And so all over the world, people have tried to come up with different scales. The one you see on your screens there is just an example. It's a universal pain assessment tool. And it's trying to use a visual analog scale to allow people to look at it and get a sense of how they would grade their pain. And because pain is subjective, it then can be influenced by what has been your past experience with pain. What is your current emotional state? So, for example, we know that when people are stressed or agitated, their sense or their perception of pain becomes heightened. What about cultural factors? Sometimes cultural factors like stoicism influence how people handle and report pain. In some cultures, it'll be much more required, or some cultures might consider it macho to downplay pain. And then there are things like the personal and the genetic factors. not just the expression of certain genes and certain neurotransmitters in your body. And finally, the context. What's the particular context in which this pain is being experienced? Does that affect how you are going to express it and describe it? Another interesting thing about pain, and we'll see the physiological reason for this in a little while, is there are so many words used to describe pain. These words, some of them are universal, like pricking or burning, but some of them actually are very cultural. For example, here in the Caribbean, one word that's often used to describe pain is gas. And that describes any pain that seems to be associated with the abdominal region can be described as gas. Now, all of these words then make it difficult sometimes for a clinician or a researcher to actually get to the meaning of pain when somebody says sticking or aching or it's a gas pain. Therefore, there's a protocol in how pain should be assessed, the types of questions that you must ask when you're considering how a person is experiencing pain. And those of you studying medicine or dentistry, I expect you will look at that in a little bit more detail in another component of your course. Now, given that pain is such a large component of the human experience, and given that pain can cause so much trauma and difficulty for us as human beings, it's obvious to ask the question, well, why do we have pain? And the truth is, we believe that pain is a protective experience. And the reason you experience pain is to warn your body and to allow your body to understand that something is going wrong somewhere. Some part of your body is in danger. Some part of your body is undergoing tissue damage. And in the short term, that might require you to remove yourself from a particular situation. For example, if you touch something very hot, that pain signal immediately activates the withdrawal reflex and allows you to protect your limb from being burnt. In other situations, that pain signal might tell you to immobilize an area. This is where we might have chronic pain associated with, say, for example, a sprained ankle or a broken bone. Here, the information is telling you that that tissue has been damaged. In order for it to recover and for it not to experience more damage, you need to immobilize the area. And so we're pretty much settled on the fact that the reason why pain is so important to us is it tells us when something is going wrong in the body. And you can see this in persons who lack pain receptors. For example, in some types of neuropathies, like diabetic neuropathy, where there's a loss of pain receptors due to degeneration of the peripheral nerves. The result is persons can experience small cuts on their feet. And because they don't feel the pain associated with it, these can become ulcerated. And this can even get worse and lead to gangrenous feet and limb amputations. All because we're no longer perceiving the pain as important to signal to us something has gone on. So now we've had that introduction to pain, we can use that outline of those 4 questions to start talking a little bit more about what are the physiological processes involved in pain. And we know that when we ask the question, what is it? We want to focus on what are the receptors responsible for pain. And we call those receptors nociceptors. Now, the nociceptors, the pain receptors, are found on 3 nerve endings. And there are 2 particular nerve endings that are important for pain perception. The first are the A delta fibers. These fibers are myelinated, and they are responsible for what we call fast pain. The second type of fiber is the C fiber. These fibers are unmyelinated, and they're of a smaller diameter than the A delta fibers. And so for those 2 reasons, 1, they have smaller diameter, and 2, they are unmyelinated. They transmit signals at a much slower rate than the A delta fibers. And they are responsible for what we consider slow pain. Now, these 3 nerve endings are found in almost all tissues of the body, your skin, your muscles, your joints, your blood vessels, in your viscera. The one tissue where we find no nerve endings, actually, very interestingly, is brain tissue. And that's been used in a couple of movies, and it's also used in surgery. The fact that during brain surgery, we are able to stimulate certain parts of the brain and use it to help us find certain locations is simply because we don't have pain receptors there. Now, there are three broad classes of pain receptors found at the ends of these nerves. The first is mechanical, and these mechanical nociceptors are activated by stimuli like pinch or sharp objects that penetrate and squeeze the skin. As we said before, these usually involve the A delta fibers. The second are our thermal nociceptors, and these are activated by extremes of temperature, cold temperatures below 5 degrees or warm temperatures above 45 degrees. These activate our thermal nociceptors. And finally, there's a third class called polymodal nociceptors. And these can be activated by many different stimuli, including mechanical stimuli, including changes in temperature, but also importantly, several chemicals like acids or strong alkalis can activate these polymodal receptors. And these receptors are connected or found as part of our C fibers. So the first two are more commonly associated with our A delta fibers, but the third class, the polymodal, they tend to be associated with the C fibers. What is really the actual stimulus for pain, though? What actually activates these nociceptors? Is it pressure? Is it temperature? And the answer to that is actually all of the above. But all of the above goes through a common mechanism called inflammation. That's a result of potential or actual tissue damage. And you would have studied the process of inflammation before, and you would recognize that when the inflammatory process takes place, there are several mediators of inflammation that are released. Some of the more common ones are bradykinin, histamine, several prostaglandins, and substance P. Now, all of these substances, which are mediators of inflammation, have the ability to actually activate the nociceptors. And so the stimulus for nociception is actually the mediators of inflammation. This slide just gives you a little bit more detail about these mediators, but many of these you're very familiar with. So for example, we know histamine is released from mast cells, and it's important for dilating blood vessels and causing smooth muscles to contract. It's an important component of the allergic response. That also can activate nociceptors. Bradykinin is also released by mast cells and can activate nociceptors. Substance P is a peptide neurotransmitter that's released from the end of nerves and is involved in the neuroinflammatory process. And is a very potent stimulus of the nociceptors and also sensitizes the nociceptors to the other mediators of inflammation. And of course, prostaglandins are a key component of the inflammatory response. Is there an actual receptor found on these free nerve endings? This work is fairly recent, and there's a particular receptor that has now been identified. It's called the TRPV1 receptor. Other names are the capsaicin receptor or the vanilloid receptor. TRP stands for transient receptor potential, and V stands for the V family. It's a member of the V family. So it's a very long name, but we just call it the TRPV1 receptor. Now, this is a non-selective cation, and it's found on these free nerve endings. And a number of stimuli we now know activate these receptors. Temperature, acidic conditions, capsaicin, that's how it also gets its name, which is the active ingredient in hot peppers. This activates these receptors. The pungent compounds found in mustard and wasabi, those of you who are familiar with Japanese food and sushi, these also activate these TRPV receptors. And so these TRPV1 receptors are now considered to be the receptors for pain on the free nerve endings. Interestingly, these receptors have widespread distribution, not just on three nerve endings mediating pain, but they're found all over the central nervous system and have become an important research area of focus as we try to understand what exactly is their role beyond mediating pain in the periphery. Now, we just mentioned a little while ago that our nociceptors are found on two different nerves, the A delta fibers and the C fibers. And this gives rise to two different types of pain, which we tend to refer to as fast pain and slow pain. But sometimes we use the term acute and chronic. And the best way to think about this is to think about if you've had an experience with pain. Like a common experience many of us would have had is to touch a very hot object, usually when you're cooking. And when you touch that object, you get an immediate acute pain, fast pain, a sharp pricking that causes you to withdraw your hand. It's fast and it's intense, and there's an immediate response from you. But a little while after, within about a minute, you notice that perception of pain actually begins to change somewhat. And now, instead of experiencing that fast acute pain, it has a kind of slow, aching, dull, throbbing consistency to it. And we call that the slow pain. The fast pain is by the A delta fibers, the slow pain by the C fibers. But the slow pain is also the fact that after the fast pain, these mediators of inflammation that we just spoke about begin to activate the inflammatory response and begin to change the perception, the quality of the receptors around the site of injury. So this table here just summarizes the difference between our C fibers and our A delta fibers. We see that there are commonalities. They are primary afferent fibers. The C fibers are smaller than the A delta fibers. But we should say that the A delta fibers, in the context of all nerve fibers, are actually small fibers. The C fibers are unmyelinated, A delta myelinated. The C fibers are slow conducting, the A delta relatively fast conducting. The end result is you get a different type of pain experience. The pain quality for the A delta fibers is well localized. You can identify it exactly where on the body. It's sharp, it's stinging. Those are how we describe it. Whereas the C fibers, it has a diffuse, dull, aching quality. And because of its second order neurons, as we'll see in a little while, it's difficult to localize. We often refer to this as slow pain or pain. The final thing about nociceptors that I do just want to mention is there's a group of nociceptors called silent nociceptors. Now, these nociceptors are found on the viscera. The viscera are our internal organs in the peritoneum and the abdominal cavity. And they are not usually activated unless there's some type of inflammatory response. So if a different process is taking place within these organs, if something is going wrong, and there's a level of inflammation within the viscera, those mediators of inflammation then activate these silent nociceptors, and then they become activated. And that's when you get this diffuse sense of abdominal pain. It's often very difficult to localize, but depending on the extent, can be extremely painful and can cause tenderness or even guarding, where the abdominal walls become very tense as the body seeks to protect the internal organs. Now, I just want to introduce you to a couple of concepts associated with pain, and associated with the fact that pain is so tightly linked to inflammation. And the concept we want to talk about is the fact that the level of pain perception is often greater than the degree of tissue injury. And this makes sense. If the reason we have pain is we want to protect the body, then what we're saying is we get an exaggerated response when compared to the actual extent of the injury. And this leads us to two concepts that are very closely related. The first is hyperalgesia. and that increased sensitivity to an already painful stimulus. So think of a pinprick. We know that's a painful stimulus. But if a situation occurs when your skin or your body becomes increasingly sensitive to that pinprick, we call that hyperalgesia. The second definition, or the second term, is allodynia. In this case, normally non-painful stimuli are now felt as painful. So think about a wisp of cotton or using a Q-tip. Usually, if you apply that, say, to the skin, it wouldn't be painful. But situations where that now becomes painful, that will be described as allodynia. And in the image there, you see a very good example of this. When someone experiences sunburn, the areas of the skin that are now burnt experience both hyperalgesia and allodynia. For those of you who have experienced sunburn, you know that the usually non-painful experience of putting on your shirt can suddenly become very painful as the cloth brushes against your skin. That would be allodynia. And you would know if you have sunburn and you have bad sunburn, and you apply a pinprick, whereas previously you might have been able to endure that pain, you immediately have a withdrawal reflex because there's now hyperalgesia. And in both cases there, what the body is doing is, because there's been inflammation, the body has an enhanced pain response to protect you, to protect it from further injury. Now, hyperalgesia can be divided into both primary and secondary. Primary refers to the site of the injury. So in this little demonstration here, somebody has received a burn, and the burn is found in this red area here. But because of inflammation, the area around the actual burn also starts to get very inflamed. Primary algesia talks about an exaggerated response in the area of the injury. Secondary algesia talks about an exaggerated response around the area of the injury that was not directly damaged, but because of the chemical mediators of pain spreading the information around, it also becomes sensitive. And you can see that both for sites A and B within the primary area, and also for site C within the secondary area, after the burn, there's a much more sensitivity to pain. The pain threshold has now decreased compared to prior to the injury. Okay, let's talk a little bit about the pain pathway. Now, of course, this is a video, and you can pause the video right now if you find a lot of information is coming at you, and take a break and come back to this. Now, in other sessions, in your reading, you probably know that the pain pathway is the spinal thalamic tract. And the spinal thalamic tract is composed of a series of neurons, which you have heard described as your first order neurons, your second order neurons, etc. The first order neuron of the spinal thalamic tract, like all sensory neurons, enters the spinal cord from the periphery via the dorsal horn or the dorsal root. You can see here. Here, it synapses in the dorsal horn of the spinal cord and gives rise to the second order neuron, which crosses immediately to the other side of the spinal cord and ascends in the spinal cord contralaterally, the lateral spinal thalamus. And from here, it ascends all the way to the thalamus, where it synapses with the third order neuron, which then goes to the somatosensory cortex. Collectively, this is our labeled line code. And the important thing here is we see the pain pathway, the spinal thalamic tract, crosses as soon as it enters the spinal cord. And of course, that has implications for us being able to identify particular lesions or particular syndromes like Brown-Séquard syndrome and anterior cord syndrome, etc. Now, within the actual dorsal horn of the spinal cord, there's a particular architecture or arrangement of how the pain receptors and the pain fibers work. Now, you will know that the dorsal horn is histologically divided into laminae. And you can see some of these laminae highlighted on the diagram there. What we find is that lamina 1 receives fibers from our A delta fibers, but A delta fibers also go to lamina 5. In lamina 5, they interface with a particular type of neuron called the wide dynamic neuron. I'm going to talk about that in a little bit. The C fibers go primarily to lamina 2, a region called the substantia gelatinosa, and they interface with interneurons, which you see there also then eventually synapse onto our wide dynamic neurons. Now, this gives rise to the fact that we have two types of second-order neurons that involve in the processing of pain. The first are high-threshold neurons. And these high-threshold neurons are associated with lamina 1 and associated with our A delta fibers. And these help localize because they have good spatial resolution. They help localize pain. And that's why our first pain, our sharp pain that comes from the A delta fibers, has good spatial resolution. The second type of fiber is the wide dynamic neuron, which we just mentioned is found in lamina 5. That gets information from the A delta fibers, but importantly, it gets information from the C fibers as well. And these wide dynamic neurons have many dendritic processes and get information from wide regions of the spine. And as a result, that information is poorly localized and diffuse. Hence the reason slow pain is not as well localized as fast pain. So, just highlighting this again, our high threshold neurons are called nociceptor specific because they only get information from pain fibers. They have small receptive fields and therefore they provide better stimulus localization. And the transmitter between the first and second order neurons is usually believed to be glutamate via an AMPA receptor. The wide dynamic neurons, they get information from both the A delta and the C fibers, but they also receive information, as you can see here in this diagram, from our A beta fibers that are important for carrying information about the child. Because of all of these sensations, they have large receptive fields and are poorly localizing, and they can be modulated by other neurons. And we're going to see that in a little while when we talk about referred pain and gate control theory. So let's talk about that. Let's talk about referred pain. What exactly is referred pain? Well, referred pain is pain in a region of the body where that part of the body is not the source of the pain stimulus. Now, there's a program that used to air on television in the United States many years ago called Sanford and Son. And in it, the main protagonist, irascible old man, often would fake that he was having a heart attack. And every time he's pretended to have a heart attack, he would put his hand over his heart, and it would seem to suggest he's experiencing pain from his heart. But we know that if you experience heart pain, you don't actually feel it in the left chest region. You actually feel it in the left shoulder and radiating sometimes down your left arm. That's an example of referred pain. You are experiencing the pain in your left shoulder, but the point of origin of the pain is the heart. And so the pain in the heart is referred to the left shoulder. Now, the question we want to ask is, well, that's unusual. Why does that happen? How does it come about? Because it seems to suggest no useful purpose in the human body. Well, this experience of referred pain is usually associated with viscera. And remember, we said viscera have silent nociceptors that are not usually active. And the reason it happens is because of convergence of visceral and somatic afferents. Both pain pathways, say from the heart and from the left shoulder, converge in the same place within the spinal cord. And then when the information goes up to the brain interprets it as coming from the shoulder because it's not accustomed to getting information from the heart. Those receptors are usually silent. So when there's convergence, the brain interprets it, oh, that pain must be coming from the shoulder, because that's usually where I get touch pain information from. Now, the question we want to ask ourselves is, well, why does this convergence occur? Isn't it a bit strange that you have convergence of the heart and the left shoulder? And the reason for this comes from embryology. Many of the viscera, where they end up is not where they started. So the heart, it originally started in the same dermatomal region as the left shoulder. But as the body developed, the heart would have migrated and ended up in its current position in the adult or child body, a little bit away from the left shoulder. As it migrated, the nerves went with it, but the nerves still converged on the same place within the spinal cord. And that's why it's believed we get referred pain, because the nerve from the heart and the nerve from the left shoulder originally came from the same dermatome. Therefore, they still converge on the same place within the spinal cord. And as I said before, because information does not usually come from the heart, when that pathway gets activated, it gets interpreted as coming from the shoulder because of convergence. Now, the best example of referred pain is usually heart pain. But most of the viscera have their pain referred to other parts of the body because of this embryology, as I just explained to you. This diagram just gives you a couple of examples. So here you see, for example, the liver, which is found on the right side. You can see that it's referred to the right shoulder, just like the heart is referred to the left shoulder region. And you can just look at this diagram, pause the video, and just familiarize yourself with examples of where pain is referred to in different parts of the body. Okay, the next topic that we want to consider is the modulation of pain. And we're going to look at two particular theories. The first one is called the gate control theory of pain. And on your screen, you see three examples of that. But let's start with the third one, because we've been using this example often. You're in the kitchen and you're cooking, and you touch the pan or you touch the fire, and it's very hot. And you immediately withdraw your hand. We know that's a withdrawal reflex. We've seen that that's important to protect your tissues from further injury. But many of us would know that if we do that, we often start to do this. We often start to shake our hand. Why do we do that? Well, something about that shaking appears to reduce the sensation of the pain. Or for example, you're running and you stub your toe, you hit your toe. That can be very painful. And you immediately bend down and begin to rub it. Or you hit your knee and you start to rub it. Why does rubbing reduce the pain? And then finally, sometimes if you've been to the doctor or to the nurse to receive a vaccination, sometimes they might just distract you and tap the area of the skin where you're about to have the injection at the injection site prior to the vaccination. And that sometimes helps reduce the pain. All of these are examples of the gate control theory, in which activation of the touch receptors is being used to reduce the perception of pain. So what's actually going on here? Because you know it actually works. You know if you've hit your knee and you actually start to rub it, it does feel a little bit better. Not just because of the time lapse, but something does seem to happen. Well, a theory was put forward in 1965, and it still holds a lot of sway and influence today. And it's called the gate control theory of pain. And the basic idea is that the dorsal horn acts like a gate, and it lets signals for pain through, or it closes the gate and it stops the signals coming through. Now remember, the dorsal horn is where we have our pain fibers coming in. And in particular, our C fibers synapse on Y dynamic neurons. You remember that. But we also said that the fibers, our A beta fibers, also synapse on the Y dynamic neurons. What seems to happen is the A beta fibers send an inhibitory signal to the second order neurons and to the first order neurons of the C fibers and basically inhibits the pathway. And so what happens is when you activate the touch receptors, they send an inhibitory signal to inhibit the pain pathway. And so less signals go up to the brain along the pain pathway, and they're now replaced by the touch signals. And so there's a diminishing in the perception of pain. Basically, the activity of the mechanoreceptors and the touch fibers seems to close the gate and stop the pain signal being transmitted all the way to the brain, reducing the perception of pain. So there are many videos online which you can see this in dynamic action and via animations, and you can read about this some more. Now, this is a reasonably effective pain reduction strategy, but it's not massively effective. It's not massively effective. Let's talk about a system that can actually be much more effective, and it's called the descending control of pain, or the descending analgesic system. And this is because there are certain midbrain structures that can also close the gate, but to a much greater extent. A good example of this is reports of soldiers who have been on the battlefield and received gunshot wounds and have not noticed the pain. Only after the battle has ended and they've returned to camp will a colleague indicate that they now have a gunshot wound, or they will begin to experience the excruciating pain associated with that wound. Another example is an athlete who's playing an intense match and injures part of their body, twists their ankle. They're able to recover pretty soon and continue to play with minimal pain. But after the match, they experience great severe pain and sometimes cannot even walk, to hobble around. In both of these situations, we saw a significant amount of pain reduction. And both of these situations were associated with high stress conditions. And so that tells us something about what's happening. It seems there are certain conditions when there's a lot of stress, when there's a certain demand that's placed upon the body, that are able to activate these descending pathways and reduce the transmission of pain and the perception of pain. Now, there are two systems found within the midbrain that help in this descending pathway. And the first is serotonergic, and it's activated via the periaqueductal gray matter, connecting to the nucleus raphe magnus and moving down into the dorsal root. And then there's a second system in the locus coeruleus that also goes straight to the dorsal root. The one that's been better studied and better understood is the serotonergic system associated with the periaqueductal gray. Now, this system receives input from the hypothalamus, the amygdala, and the cortex, areas that will be very active during times of stress. And you can see that there's a neuron from the periaqueductal gray that releases an enkephalin that then stimulates the neurons in the pons and the medulla to release serotonin from the nucleus raphe magnus. And then this serotonergic neuron activates a small interneuron in the spinal cord to release an enkephalin. And this enkephalin inhibits the pain pathway. It closes the gate, and stops pain signals ascending to the brain. As we've said, this is a very powerful pathway. The locus coeruleus also gets these signals, and it activates noradrenaline, which in turn can then activate these enkephalin-releasing neurons. So that's our descending pathway, and it's making use of enkephalins, which are the body's endogenous opioids. And as we're going to see in a little while, opioids are very powerful pain modulators. So please do some reading on this and appreciate the importance and the significance of this descending pathway. Some people have even suggested that this can be used to do surgery, the activation of these pathways. So let's talk about some drugs or some chemicals that are used to relieve pain. And the first one we're going to talk about are the opioids. We just mentioned enkephalins. The opioids are extracted from a particular poppy plant, and you get the illicit drug opium, and that can be made to used to make other illicit drugs like morphine. But these drugs are not just street drugs designed to produce a high. They have many, many effects and have been used for thousands of years across societies because in addition to the high, they've reduced pain. They are useful for sedation, calming people down. They relieve diarrhea, and they're important for cough suppression. Now, the reason these drugs work is because your brain has its own naturally occurring opioids, and your brain actually has opioid receptors. The naturally occurring opioids are known as endorphins and enkephalins, and we just saw the power of some of these enkephalins in the descending analgesic system. Now, these enkephalins act on a number of receptors, and more receptors are being discovered all the time. But the two that we understand the best are the mu receptors. Mu1 is located outside of the spinal cord, and they're found a lot in the brain and for the central interpretation of pain. Whereas the mu2, they are located all throughout the CNS. They're the ones I really want you to focus on. There are other ones like delta, kappa, and now sigma, but we're not too sure exactly what they're involved in. How do these receptors work? Well, we find them both presynaptically and postsynaptically. And they seem to be able to reduce the transmission of currents by inducing hyperpolarization. So it seems that via the activation of G proteins, they're able to open potassium channels, increasing potassium conductance and leading to hyperpolarization of postsynaptic cells. And of course, that means the cells will be less likely to fire. It also means that presynaptically, there'll be less chance of neurotransmitter release. And presynaptically, they also seem to block calcium channels that are also important for neurotransmitter release. So overall, these enkephalins seem to be able to reduce neurotransmitter and to reduce signaling within the systems of the body, hence their role in pain. But of course, these receptors are widespread throughout the central nervous system. And so we have other effects that I've already mentioned to you. They lead to sedation, that is drowsiness. They lead to cognitive impairment because of that sedation. And of course, they give a sense of tranquility. All of these things are associated with a sense of reducing anxiety or anxiolysis. These drugs also, though, they can inhibit the central control of respiration. And if you give too much of them, they can actually lead to respiratory suppression. And the main cause of death is actually when you get an overdose within these drugs and respiration ceases. So that's one of the challenges associated with these particular drugs, especially when they're used illicitly on the streets. These drugs are used for cough suppression and cough medication in the form of codeine. These drugs also cause pupillary constriction. And so in uncontrolled use, this is a sign of an overdose where you have pinpoint pupils that do not respond to light. These drugs help in the control of gastrointestinal symptoms, as they can help relieve diarrhea. And so they're used in those situations. But they can also cause nausea and vomiting by activating the chemoreceptor trigger zone. And finally, in some cases, these drugs can release histamine and cause allergic reactions and itch, and also affect white blood cell and immune function. What's the take-home message? These drugs have a lot of benefits, but because of their widespread use, and because of the fact that they do have addictive qualities, their use must be very closely monitored. And they shouldn't just be used randomly, definitely not in the form of an illegal drug. The other most well-known group of pain-killing drugs, of course, is our NSAIDs, or non-steroidal anti-inflammatory drugs. And you can think of many examples of these, and I'm particularly not going to give them to you. Because if you don't know, I want you to go and look them up right now. Now, these drugs act by blocking a key enzyme in the body called cyclooxygenase, which is responsible for the synthesis of prostaglandins. So we just saw a little while ago that in the process of inflammation, one of the key mediators is prostaglandins. And if we can block those prostaglandins, then we can slow down on inflammation. And that's when it helps in the reduction of pain. So prostaglandins promote inflammation. They're also involved in promoting fever, and they also lead to pain perception. So if I block the cyclooxygenase associated with that by giving, I won't give you the name of an NSAID, then I'm able to reduce pain, reduce fever, and reduce inflammation. And immediately you should be thinking about what common drugs you know do these. All of these things happen because of a particular pathway, the cyclooxygenase 2 pathway. But in other parts of the body, there's another COX enzyme called cyclooxygenase 1. In the stomach, that's used to produce prostaglandins that protect the mucosa from the high acid conditions. That is also used by platelets to reduce platelet aggregation, to stimulate platelet aggregation and clotting. And it's also used for vasodilation. Those are what we call the beneficial prostaglandins. So if you give a substance that blocks this pathway, then we will have reduced protection of the mucosa. And that means a side effect of long-term NSAID use can be damage to the stomach lining, possibly ulcers. And this happens with people who take NSAIDs over long periods of time for pain. Like say persons involved in contact sport have a lot of pain. If we block cyclooxygenase 1, we can reduce platelet aggregation and reduce clotting. That might be useful in persons who might be at risk of stroke. And that's where we also use some of these drugs. So this diagram just summarizes it and now gives you a couple of examples of the NSAIDs. So you can see that if you have a tissue injury, you can see that the tissue injury leads to production of 5-phospholipids and then arachidonic acid. And that's what's acted on by COX 1 and 2. And you can get your cytoprotective prostaglandins, aid in protecting the gastric mucosa, platelet aggregation. But you can also get your inflammatory ones that activate pain receptors, regulate temperature, and stimulate inflammation. And in both cases, when you use our typical NSAIDs, they tend to be non-specific. They tend to block both COX enzymes. So you need to have an understanding as a future health professional about these two important pain pathways, those activated by the opioids and those activated by the. Let's look at one last thing concerning pain as we come to our close. And let's talk about abnormal pain states or neuropathic pain. Now, I just said that pain is usually associated with injury and inflammation, and it's a protective response. But sometimes something goes wrong in the nervous system that's actually responsible for transmitting the pain signals. And the result is that the system that's responsible for transmitting the pain signals, something goes wrong there. And now it's firing when it shouldn't be firing. And that means you're now getting pain that's really of no value. It's not signaling tissue damage. It's a sensory system that's gone out of order. And these situations can be very, very challenging and very difficult to manage. A couple of examples of that are diabetic neuropathy and other neuropathies that I just told you about, where as the nervous system is under attack and the neuropathy continues to develop, it causes random and uncontrolled firing, not because there's tissue injury, but because the nerves are under attack and being damaged. Phantom limb syndrome is another good example, where there's been an amputation, and because of spontaneous firing of nerves, you get pain from a limb that's not even there. trigeminal neuralgia or pinched nerves are other examples. And this list is growing. We often refer to these syndromes as neuropathic pain syndromes. And because they're not a result of tissue damage, the management is often a little more challenging. And we can't just simply use things like NSAIDs or opioids. Often we have to use membrane stabilizers or different drugs to try and treat these conditions. And those of you who get involved in further studies in this area and the treatment of these conditions will appreciate this more later on. And so that's it for our study on the physiology of pain. As I said at the beginning, pain is an experience that's common to all of us as humans, and it has a massive effect upon us. It's not a typical sensory condition because it's so important as being a protective mechanism. It also has strong emotional components, and that leads to all kinds of interesting situations. But the understanding of the physiology and the anatomy of pain is very important as we seek to combat pain and make our lives a little bit better, even as the pain warns us of things going on in our body. So until I see you again in another lecture, take care and keep safe.